Yeah. Right, right.
I've already been to World War II. And they asked Penny if they could please last year. We did have a final Guttenberg. I think he was really cross. He was the final match in our final man in POWs. And I guess 4 questions were asked.
You are now out of the shot.
So I'm going to go. Let me know what I will. I'll time for it. We'd like to get some of the folks before they pass away, but we'll also anything. So we're doing it, but that's all I have.
6. Oh my gosh, it's terrifying.
I'm gonna sit down and just review things. So. And I'm sneaking out of the lid on some of these. Okay, give me your person. That's quite all right. I don't have to set up. So with just Representative Brownlee and I, it may be fairly rapid. Or this is good. Sorry. Good to see you. Good to see you again. Thank you so much. So. I was coming home from someplace and I saw you on my road one day and I was lay on my horn. Yeah. I'm not scared. I should have. You were driving. I was driving. Yeah. Don't distract me. I'm Karen with it too. When did you fly in? Yesterday. So these are interim chief of staff. So you know, Dr. Mizraki, so yeah. So where'd you come from?
I was actually with us.
I see. They're first year college. I love it.
Oh, I bet she does. Yeah.
One of the business cards I'm going to just because that I'm going to do this is how to
Are you on the
teach me and write the Jamie that's 4 months she's in here now. And the bridal, the wedding.
Right.
Yeah.
Oh, I thought that was amazing.
So we, as part of the pageant, we did military substitution, so we had room about, we had 3 couples lined up.
They did?
So the chief of EMS asked his grandfather, hey, could you come at 65 years?
Oh, that's nice.
They use the same words, or at least the same, they use the same vowels as had all the
Yeah.
words.
That was my anniversary as well.
Yeah.
No, I was just reading about it.
It was very well received.
I
Yeah.
bet. I think being the first one, right? So I think it probably, I was sharing. it
Yes,
with
I
you
think
first.
so, yeah. We did a really good job, and I asked them what their secret was. Patience, they both said patience at the same time.
We had a baby shower. The baby shower.
The baby shower, I bet one.
Yeah, the baby showers are always I actually did my undergrad. USC. Yeah. I'm not sure. I wanted to finish
But I have a picture of it. The ones that all of them are important, but I tried to.
Oh my God.
Here comes the best.
Thank you for asking.
That's like, oh yeah.
You don't know.
No.
Oh, yeah.
Nice to meet you.
Everyone is. It's easier. Coming from all down.
They haven't shown me about this.
I'm not gonna say way back for that date. We actually changed the line.
There's a possibility of likely
Yeah, yeah. Nice to see you.
It is.
Get them involved when that's part of the cost. So they're more like. Yes.
Stay in Iowa.
Well,
50% will stay in the
Right.
but we also, you know, they go on that side.
Well, yeah.
Yes.
Okay. Good morning. This bill hearing for the Subcommittee on Health for the U.S. House of Representatives Committee on Veterans Affairs will come to order. My name is Marionette Miller-Meeks, and it's my pleasure to serve as the Congresswoman for Iowa's 1st Congressional District and the chairwoman of this subcommittee. Before we begin, I want to thank the students, faculty, and staff at the University of Iowa for providing us with this space to host this bill hearing. It's a great day, truly, when I get to spend it in the Hawkeye State and the Hawkeye community here in Iowa, and also part of the University of Iowa, where I did my residency and was the first woman on faculty at the University of Iowa's Department of Ophthalmology. I also want to thank my colleague and friend, Representative Julia Brownlee from California, the ranking member of the subcommittee, for traveling to the district for today's hearing, as well as Dr. Clancy. And I look forward to visiting Representative Brownlee's district in a few months for a field hearing with California veterans and stakeholders. And I also want to thank the VA for being with us here today. Our VA here in Iowa City is known for its quality and expert care. As residents at the University of Iowa, we train at the VA as well. Many of the faculty have dual appointments, but it really is an institution of excellence, and proud to have this, our VA hospital in my district. And if I could just pause for a moment, there may be some veterans in the audience, and so could you raise your hands or stand if you're a veteran? Could we applaud them, please? Thank you so much for your service to our nation. Both Representative Brownlee and I feel that it is a pleasure and an honor to serve you in Congress. First, I'm going to point out that some of members of my staff are here, both my district staff and my DC staff, so if they'll stand, they'll point themselves out to you. And if any of you have veterans-related issues, please feel free to stop by and ask them questions when you're leaving. The format for today's hearing is set up to allow the audience to listen to the proceedings and the testimony of a congressional hearing as if we were in Washington, D.C.
It is not a campaign event, just to make sure everyone understands. This is an official hearing. But if you do have issues or concerns, my staff can help you with any of the following issues you may have at the end of the hearing. As a physician and a 24-year Army veteran, it's my top priority to ensure that the VA delivers state-of-the-art modern healthcare to veterans nationwide. I know firsthand how important technical advances in healthcare can be in ensuring that we accomplish our duty as clinicians. This mission requires constant oversight and attention to keep moving the ball forward. During today's hearing, we will discuss the transformative work that is being done in the veterans healthcare space, work that the VA healthcare system is a leader in, as well as hearing from some of the constituents in my district who are leading the way in healthcare and veterans entrepreneurship. We'll also discuss the partnerships the VA has made with private healthcare providers in Iowa to ensure that every veteran has access to the care that works for them. Finally, we'll examine the breakthroughs in artificial intelligence and ophthalmology that were pioneered right here in our state, as well as discussing artificial intelligence that's used throughout. There are some entities that are not yet at the VA, and we know that Dr. Clancy is working on that. Recently, I've had the pleasure to visit with a group called Clear Force, which is using suicide risk, behavioral modifications, and then artificial intelligence to help us to identify people earlier than when they get to the point or having to call. So it's a proactive way of reaching out to veterans who may be at risk for suicide. There are also work that's being done with augmented reality or virtual reality for treatment of PTSD and depression and avoidance of suicide, which we know that the VA's, one of its top priorities is to reduce the numbers of veteran suicides. As I previously stated, innovation in healthcare is a topic that's very close to me, and I support pushing the technology envelope to reach new heights in quality medicine for veterans and all Americans. The University of Iowa Healthcare System, in partnership with the VA's Central Iowa Healthcare System, has done exactly that. The Iowa City VA Medical Center is ranked 33 out of 154 training sites for clinicians VA-wide, and the University of Iowa is also ranked highly when it comes to research and funding among U.S. public institutions. The University of Iowa Healthcare System was also the first hospital to offer patients access to AI technology in the field of ophthalmology, with technology that diagnoses diabetic retinopathy pioneered by Iowa's own Dr. Michael Abramoff. One of our witnesses, Dr. Mansour, who works with Dr. Michael Abramoff, is here today and will be speaking more on this later. I'd also like to take a minute to expand a bit on another important AI venture, VA's ReachVet program. ReachVet is a predictive AI model that identifies veterans who may clinically benefit from enhanced care, outreach, and assessment of suicide risk. It then flags these veterans for further care. This program is active in 28 VA sites and has been able to identify around 6,700 veterans per month. It is with breakthrough technology like this that we're able to make a difference and save veterans' lives. And in a rural state like Iowa, being able to have predictive models and outreach without necessarily having a footprint in the community is very important. It is with this breakthrough technology like this that we're able to make a difference and save veterans' lives. I really am excited to be here. I look forward to this discussion we'll have today. And once again, I want to thank Ranking Member Brownlee for traveling to my district, Dr. Clancy as well, and I yield time to her for her opening statement.
Thank you, Chairwoman Miller-Meeks. I want to thank you really for inviting me to your home state and for the hospitality we've received so far. It's really a privilege to be here. I always appreciate the opportunity to hear directly from local VA medical centers and the stakeholders and innovators that are working with them to provide the best possible care for our veterans. VA medical centers and facilities do not exist in a vacuum, and the partnerships that VA creates with local communities are extraordinarily crucial. I am glad to be here to hear more from the VA and from the local community members about the partnerships that have been created and how we can continue to leverage those to innovate and improve care for our veterans. In a community like Iowa City, where a university is the lifeblood and center point of the community, those partnerships and opportunities for innovation are the most evident. I have enjoyed learning more about the relationship and the VA in my preparation for this hearing, and I'm impressed by the research and innovation you have been able to accomplish thus far. Great ideas and innovations can come from many different places, and it's important that we support and encourage VA to take those ideas in, whether they come from the private sector, academia, veterans, or from VA's own employees. It will also be important for the VA to have set processes in place to evaluate these ideas and determine which ones add value and quality to veterans' care. I'm very impressed by the research program at the Iowa City VA healthcare system, and in particular, the work of the Research Center for the Prevention and Treatment of Vision Loss. While the breakthroughs in treatments discovered by the center can and should primarily benefit veterans, it's also true that its work will benefit the general population as well. We should make sure that VA can communicate with its community partners to share those innovations. I'm looking forward to hearing more from Dr. Mansour and Mr. Blankenship about their experiences and successes, and I hope to hear more about their ability to coordinate with the VA to share those innovations. Thank you all very much. Again, thank you, Madam Chair. I'm delighted to be here, and I look forward to hearing from all of you.
Thank you very much, Ranking Member Brownlee. I'd now like to introduce the witnesses. On our first panel, we have Dr. Carolyn Clancy, Assistant Undersecretary for Health for the Office of Discovery, Education, and Affiliate Networks at the Veterans Health Administration. Dr. Victoria Sharp, Deputy Chief of Staff at the Iowa City VA Healthcare System. Dr. Clancy, you're now recognized for 5 minutes to deliver your opening statement.
Good morning, Chairwoman Miller-Meeks and Ranking Member Brownlee. Thank you so much for the opportunity to join you in the Hawkeye State today to discuss the status of veteran healthcare in Iowa and the state's leadership in healthcare innovation, especially around ophthalmology. I'm accompanied today, as you just noted, by Dr. Victoria Sharp, and I do want to acknowledge our two extraordinarily medical center directors, Ms. Lisa Kearns from Central Iowa and Ms. Judith Johnson-Makota from Iowa City. So the department takes great pride in providing a comprehensive range of healthcare services to veterans across the state through one of the leading healthcare systems serving veterans in the Midwest Healthcare Network for more than 50 years. Veterans in Iowa have access to a wide range of care and support options through in-person visits, telehealth services, community partnerships, and affiliation agreements with local universities, making it easier for veterans to access routine, chronic, and preventive care closer to home. The Iowa City VA Medical Center itself is equipped with state-of-the-art technology and staffed by a team of experienced and dedicated healthcare professionals committed to delivering high-quality care, offering a wide array of primary and specialty care services, including veteran-directed care, internal medicine, kidney and pancreas transplants, and more. The Iowa City VA healthcare system's dedicated network of facilities and clinics across the state, including 12 participating universities in Iowa and over 21,000 active providers, ensures veterans have access to high-quality medical care, including primary care, mental health, orthotic and prosthetic clinical services, and rehabilitation programs. Community resource and referral centers also provide services to address the diverse needs of veterans, including housing, vocational rehabilitation, and personalized support. In fiscal year 2023, nearly 500,000 community care outpatient appointments were made, a 75% increase over the last 5 fiscal years. The healthcare system has also successfully integrated telehealth to improve access and deliver specialized care to veterans. Tele-emergency care, or tele-EC, is just beginning to be rolled out in this network, offering acute, unscheduled, episodic medical care virtually to veterans who are determined to meet an emergent or urgent level of care. In other words, these veterans get access to what my family gets because they can call me, right? They can speak to a clinician 24/7. I'm worried, do I need to see someone right now? Should I be in the emergency room, or should I make an appointment as soon as I can? The platform triages over 15,000 calls with a median wait time under 10 minutes. Nearly 70% of veterans using tele-EC are less likely to need community care, reducing costs, and over 85% are Our strong partnerships support research in various diseases, including immunology, transplantation, pulmonary, and diabetic diseases. With 102 active researchers, VA has advanced patient-focused clinical trials for cancer, kidney, liver diseases, traumatic brain injuries, and post-traumatic stress. Investigators in Iowa City have also identified vulnerabilities for veterans with chronic pain and PTSD, partnering with relevant centers to educate providers. Another recent innovative approach focuses on virtual reality exposure therapy, allowing patients with multiple sclerosis to participate in safe exercise and mobility assessments. So speaking to ophthalmology just for a moment or two, in setting up the stage for our expert coming later, since 1998, the ophthalmology service in Iowa City has witnessed a significant increase in patient visits and surgeries, with over 8,000 visits a year. The eye clinic, comprising experienced and renowned nurses, optometrists, ophthalmologists, residents, technicians, and clerks, provides top-notch ophthalmological care. VA also supports education with 3 University of Iowa residents stationed at the nearby VA Medical Center. The Iowa City Center for the Prevention and Treatment of Visual Loss is a cutting-edge research facility, as you mentioned, dedicating to advancing ophthalmology and finding innovative solutions for various eye conditions. Funded by VA's Rehabilitation Research and Development Divisions, the center receives an annual core funding of $1.2 million, which is leveraged into additional federal grants from other entities of around $7 million a year. The center applies a multidisciplinary approach, exploring such areas as telemedicine, computer-aided diagnosis, neuroprotection, and neurotrophic growth factors. So let me just thank you again for the invitation to join you for this important discussion. VA remains dedicated to providing exceptional health care to our nation's heroes in Iowa and beyond. And these initiatives really underscore or underpin our Undersecretary's initiatives, placing a high priority on innovation as a strategic driver for his priorities, including at the top of the list, soonest and best care, as well as suicide prevention. As we navigate this evolving landscape of healthcare, we strive to learn from leaders in Iowa and elsewhere and are committed to upholding the mission of those who have served by continuously striving for innovation and excellence. Thank you very much.
Thank you so much, Dr. Clancy. We'll now proceed with questioning. As is my protocol when we're in DC, I typically will do questions last. So I'm going to turn to the ranking member Brownlee for any questions she might have.
Thank you, Madam Chair, and thank you, Dr. Clancy. It's great to see you again. I never thought that I would come together with you in Iowa City, but here we are. But thank you so much for being here. I was struck in reading your written testimony that you said that here in Iowa that community care has increased 75% over the last 5 years. That's a striking number. The good news is lots of veterans asking for services for their health care. But I think the point of your testimony is to talk about all of the different innovations that are here, particularly in here in Iowa, where there are lots of rural communities and that have barriers to their access to healthcare, so forth and so on, things like telehealth and VA that Health Connect. So I guess I'm trying to understand all of these great innovations, and there are lots of them in here, all of these great innovations, and yet at the same time to really address so many veterans in rural settings. So here we have all of these innovations, and yet community care continues to increase 75% over 5 years. So can you talk a little bit about that?
Absolutely. So first, our overarching priority for VA is soonest and best care. If veterans need help, we want to help them right now, as rapidly as we can, and we want to get them to the best possible care. Getting that right balance between care that we can provide because we are more finely attuned to the unique needs of those who have served versus getting them in faster in the community. At a time when the healthcare labor market is, I think to put it politely, in flux. I think there's been a lot of just yet. Some of that attributable perhaps to the pandemic and many, many other shifts. But we are struggling. I think VA has got the huge advantage of having been deployed telehealth since about 2005 or 6. Now, historically, this was almost a separate line of activity. I mean, literally separate accreditation and all kinds of things like that. The pandemic changed that quite dramatically, so that we are trying to be able to meet veterans where they are in as close to real time as possible. This is why I think tele-emergency care is such a game changer. If I'm worried now at 8 o'clock on Saturday night, I shouldn't have to think, great, I can wait till first thing Monday morning. I can actually pick up the phone now and be getting advice from a clinician in very short order. That's the direction that we're headed. I hope that helps.
Oh, thank you. I think when the chairwoman had her opening comments, she talked about veterans at risk for suicide and a program that is now identifying 6,700 at-risk veterans on a per-month basis, which I had not heard that statistic before, so I'm pretty impressed. I'm curious to know of 6,700 veterans who are identified on a per-month basis. Do you have any data, statistics to say, you know, what happens to that 6,700 population? I am assuming there's a lot of screening that goes on in each one of those cases, and we get to a place of maybe medication or something, but we might find that some veterans are really at risk for suicidal ideation. So do you have any data on that?
We do, and I'd be happy to get you more detailed readout for the record. What I can tell you with complete confidence is that we have seen a decreased incidence in suicidal ideation and suicide attempts, which we think is hugely important. To be clear, this particular model is for veterans who've been getting their care in our system. So although we feel fully responsible for all veterans, whether they're connected to us or not, this is only for veterans in our system. But it really is taking care to the next level, which is saying, you know, instead of like responding to phone calls, if you will, you remember the old pink slips that would be sitting on a pile, you're actually using AI to prioritize those at the highest risk. That, I think, is the game changer, and I think we're going to see a lot more of that in healthcare. But we track this on a monthly basis. In fact, our two directors were very quick to show me their statistics and so forth, but we can get you all that.
Thank you. I yield back.
And thank you very much, Ranking Member Brownlee. And I'm just going to dovetail on that. And it's when speaking about community care, and I think Dr. Sharp could even elucidate that more, but the power of AI to be able to deliver care remotely, to increase access to prevention and affordability, all of those things which we're all concerned about in healthcare in general, but also at the VA. I think the power of artificial intelligence or augmented intelligence really is that innovative breakthrough that we're looking for, and I think can help with a lot of that, especially in rural areas. So, which is one of the reasons that we're talking about this today. And Dr. Sharp, I'm going to ask you something. We had a hearing, the Health Subcommittee in DC on artificial intelligence in VA healthcare. And we had the chair of the Oversight Subcommittee who had brought up that he thought that if we're using AI, that we should get a consent from a veteran every time we use AI. So in your experience as the deputy chief, I'm sure that you can tell us of where, you know, some places where AI is being utilized, and would this be something that would be feasible to do to get permission from a veteran every time AI is used? Would it be cumbersome? Would you have some thoughts on that? Because as we make policy, this would be very important in actual delivery of care.
So I'm just going to start this off a little bit, just to say we are fully committed to being very transparent with all of our veterans about everything that we're doing. Clearly, if it involves personally identifiable information or their health information, yes, informed consent will be part of it. As you know, the President issued an executive order last October, and we are now working through very, very carefully, how do we go about consent and when is it that we don't. So just to give you an example where we might not. Some of our colleagues at another facility in California, but not your end of the state, Representative Brownlee, were using a kind of AI to use an enterprise scheduling approach for nursing, right? Rather than having every single unit do their own scheduling, they were looking at how much can we shift off, and also, frankly, making needed changes. Who's going to be the next person asked to work overtime in a much fairer way? You don't need informed consent for veterans from that, but that is an application of it. I'll leave it to you to.
Yes, ma'am. And Dr. Clancy, I did not mean to imply that the VA was not being transparent.
Yes.
It's more from delivering clinical care, especially when you have manpower shortage or person shortage, when you have a healthcare workforce shortage. How cumbersome would it be, and does it need to be consent for every time you're using artificial intelligence, as you detailed beautifully. So
I will just mention, we are, I think, as you know, going to be doing some tech sprints in the near future with some very carefully thought through pilots. Those, by definition, this is using ambient dictation, right? Veterans will have to give informed consent to be part of this. So we will learn on the ground how onerous it would be or not.
thank you so much. Dr. Sharp?
Oh, thank you. For now, you know, we have limited use of AI, and we are looking at many applications going forward. I mean, currently we have our AI research, and so we definitely get the veterans' consent for that. And so as we move forward, then I think we'll have to evaluate it right. We want to make sure that veterans are protected. And so we will, in the situations that we need to, just like we get consents for, you know, we do surgical procedures, we always just want to make sure that everything, you know, the veterans are protected. So we'll just have to see as we go forward to the situation.
Thank you. And Dr. Sharp, can you expand on some of the areas where the VA has improved its quality of healthcare delivery to veterans in Iowa in the last few years?
So I can talk about a couple of our programs that we feel. So our veterans, many of them are in rural areas. And so I just want to bring up a couple of things that we're doing because we want to take the care to them. We think we provide great quality care, and so we want them to get their care in the VA, although getting it wherever they need, you know, in their communities. A couple of things, though, that we've done is we have home-based cardiac and pulmonary rehabilitation programs. And it's we have the cardiac rehabilitation program going currently, and then we're going to do the pulmonary soon. But it's a tele program, and they work with their cardiologist or pulmonologist at the VA. And then we found that it's like a 12-week exercise nutrition program. So we're doing that. We've got great results from the veterans. They're very happy about it. A couple other things that we've done recently in our cardiology electrophysiology service line. We implanted our first cardiac contractility modulation device, which is for heart failure therapy, and it improves their outcomes and their quality of life. And we also we're just among a small number of hospitals in the state that are able to provide that therapy. And another thing is we just recently had approval to implant a leadless pacemaker. It's the smallest pacemaker on the market, and it's got a battery life of 16 to 17 years. So by doing these things, we think we can increase the procedures we do. We have an AP lab we're working to get, it'll be ready for us to improve these or expand these procedures soon. So we think it's great that we're doing these great things.
And there's remote monitoring with those?
I think so.
Thank you. I'll now recognize Representative Brownlee for some additional questions.
Thank you, Madam Chair. I appreciate that. Dr. Sharp, I just wanted to ask you, from your perspective, why do you think community care has increased so significantly here over the last 5 years?
Well, the reason that I think that it's increased, I think, well, one is we have an increased number of veterans that we're caring for. Also, you know, in healthcare, the pandemic probably played some role with staffing shortages, things like that. But we are working to look at the veterans that we serve. We want to make sure that they get the care that they deserve and that they want. But we are trying to do things to help them. So we are doing, you know, telehealth. We're doing these VVC visits. We're doing those type of things. We have our community care outreach clinics, and we are, traditionally it was primary care, mental health, and we're really working to expand our specialty cardiology, orthopedics. And so we are looking to expand all the services that we can. We want to take the care to them as best we can. So we're trying to help. And
So if you were gonna extrapolate COVID, because I can see how COVID would impact a 5-year data situation. If you're gonna look at that, from, for the last 2 years anyway, do you still see that kind of increase, or is it flat, is it declining? Do you have any sense of what's happening in community care?
well, and our facility, we watch it, we monitor it, and we try to make sure that we have the services. We are looking at our number of our operations, type things like that. We're kind of getting back to that pre-pandemic level. And so, and also just our referrals, as we look at it, our referrals to the care in the community, it was rapidly going up. It's not going up as much anymore. We're really looking internally, talking to the veterans, because many of them prefer to get their health care within the VA. And so trying to make sure that we have the access, looking at all those components to make sure that they can get the care they wanted, where they want it. So we hope, I mean, it could, there's no way to predict the future, but we're trying all we can to get them the care where they want, and many of them prefer the VA.
Yeah, I mean, when my conversations with veterans is that they would prefer to get their health care within the VA, and once they're in the VA, find that the health care is pretty extraordinary. And I know for women veterans, there are a lot of services that the VA doesn't offer. Pregnancy, for example. I know pregnancy, but deliveries of babies have to happen outside of the VA. There are a lot of different services specialized services for women that do not happen in the VA. You might have more services here that I'm not aware of. So I know that that's a requirement to go out to the community. There's not a choice there. So anyway, it's just, it is something that is, with community care being on the rise, I agree. I do believe that the VA can't offer all of its services without the help and support of community services. I absolutely believe in that. On the other hand, we want to make sure that we're maximizing those services within the VA to the degree that we can. Care outside of the VA is more expensive, and we would like to be using those resources to continuously improve those services, within the VA. So that's the reason I'm asking.
Yeah, so one comment about that, our women's health services. I mean, we've really worked hard in trying to, provide services. We really try to have a full suite of services for our women veterans. We have gynecologists and we have urologists and, breast surgeon. And so we really have a full suite. The maternity care, we help them get, we don't deliver their babies, but we do, we keep in touch with them during their pregnancy. We help them get their, whoever they want, but we also do baby showers and we do all kinds of things. We don't want them to feel that they're no longer connected to the VA during that time of their pregnancy. So we really try hard, and we have a number of women veterans who really love to get their care with us here in Iowa City and also in the Des Moines VA.
The ratio for the maternity care for the person who is responsible for these young women who are getting their care in the community, is it 1 to 10 or 1 to 100? Or, I mean, I've been to some VA hospitals where it's been well over 100 per, I can't remember what they're called, maternity coordinators, perhaps? Yeah.
Yes, that's actually become sort of an enterprise function. So last summer, VHA had its first ever maternal health care summit, which was just unbelievable to be there. Because it turned out across our system, many coordinators were trying to do slightly different things. So together, they have made a shared commitment to follow women for a year after they've delivered, particularly on the lookout for mental health issues, which tend to be more common in the women that we're serving, but also to let them know we're here, we've got you, and we're following, and it's not like we're saying goodbye because you had a baby and had the baby delivered elsewhere.
One last quick question, just one more. She runs a TV show. Just saying. Just one quick question. So can you roughly give me an idea of all of your veterans who are, under the category of rural veterans who distance or, there are other barriers to access to that care, sort of what percentage is in your overall veteran population?
I don't have the specific numbers, but I do know there's a large number.
So, I mean, just roughly, like, would you say
I don't even
half,
think I can
half?
guess.
Yeah,
There's,
you can't guess.
There's a lot of them, but I don't wanna.
Okay,
say
all
a
right,
number, but I
good,
don't
great.
really
I
know.
yield back, Madam Chair.
I
We
was
can
gonna
get that
try to answer that
information to you.
question. So, the first congressional district has over 50,000 veterans. We have, the Iowa City VA facility. The next clearest, our closest would be in Des Moines. So, and those are just the veterans that are registered for care within the VA system. So 50,000, one institution. We do have certainly clinics, and other opportunities throughout the state. Most of our counties have a clinic as well, but it's a large we have a large population of veterans, in Iowa and in the first congressional district. So maybe that'll help a little bit, but certainly we can get that breakdown for you as well. I have no further follow-up questions, and thank you, Ranking Member Brownlee, on behalf of the subcommittee. I want to thank you both for your testimony and for joining us today. We're going to seat the next panel, so you are now excused, and we're going to wait for a moment while the second panel comes to the witness table. Thank you very much. Welcome everyone, and thank you for the participation in today's field hearing. Joining us today is Dr. Mansour, resident at the University of Iowa Department of Ophthalmology, Brandon Blankenship, Chief Technology Officer at Pro Circular. Dr. Mansour, you are now recognized for 5 minutes for your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee, on behalf of the University of Iowa Healthcare, thank you so much for the opportunity to appear before you here today to discuss innovations in veterans healthcare in the state of Iowa. I am Masa Mansour, a resident physician at the university, completing my training proudly in ophthalmology. I have also proudly been training in the Veterans Affairs healthcare system for the past 8 years. And before we discuss the exciting progress here in Iowa, I would like to share why this topic is deeply personal to me. As a second-generation Iranian American, I cherish the values of the American heartland. We are a community rooted in unspoken truths of integrity, self-sufficiency, and hard work. This, of course, lends naturally to the American dream and the immigrant values that were instilled in me by my parents. Much of our very beautiful state is composed of rural farms and small town communities, and I promise you it is the heart of America that lives in these small towns. This means, however, our patients travel very far to access care. The social determinants of access to care quickly then become apparent. Transportation, loss of a day's wages, inability to tend to the farm, and unpredictable weather are few among many. This translates to missed appointments, delayed care, and economic impacts that are immeasurable. That is why I am here before you today to share the impact of autonomous AI in deconstructing these barriers. No veteran, Iowan, or American should ever fall into the ranks of an invisible population that does not have access to care. Complications from diabetes are the leading cause of blindness in working-age adults in our country. In Iowa, about 10% of the adult population has been diagnosed with diabetes, and it is estimated that the economic burden in our state alone is greater than $2.5 billion each year. Despite the obvious economic and health implications, many are surprised to actually learn that diabetic eye disease can be prevented with screening and early detection. In most settings, this involves a minimum of an annual visit to an ophthalmologist. Yet the social determinants we discussed are a barrier to adequate screening, both nationally and globally. This is where we have led the way in developing autonomous AI that allows for enhanced screening in a safe and important even to the smallest rural communities of our state. Let me share the story of Digital Diagnostics, an Iowa-founded AI company. Digital Diagnostics was founded in 2010 by my colleague and mentor, Dr. Michael Abramoff, right here down the street in Coralville. As a healthcare tech company, Digital Diagnostics designs and implements AI systems that can diagnose eye disease by analyzing high-quality images. Our flagship product, Luminetics Core, is an AI system designed to diagnose diabetic-related eye disease without needing a physician to ever look at the images. It is the fastest-growing patient-facing medical AI in the world. Luminetics Core effectively allows specialty service care to be performed by a minimally trained camera operator to detect diabetic retinopathy at the point of care, such as a primary care clinic, not an eye care clinic. This allows for only those who have positive diabetic retinopathy diagnosis to then be referred to see the specialist to establish a care management plan. The burden is thusly reduced for both the patient and the specialist. Digital Diagnostics has also helped pave the path for the use of AI diagnosis in healthcare. Our Iowa-led team was pivotal in establishing many firsts, including the first FDA approval of an autonomous diagnostic system in 2018, and then the creation of the first ever autonomous AI CPT code for billing and payment in 2019. Encouragingly, emerging evidence from randomized control trials highlights the impact of autonomous AI for diabetic eye exams in primary care patients to improve health equity, reduce access disparities, increase physician productivity, and improve adherence to care. We have shown at Iowa that autonomous AI is a scalable solution to a problem long considered intractable. In our state and others, AI diagnosis will increase our reach and allow greater access to our rural communities. Currently, Digital Diagnostics has more than 600 sites under contract with about 100,000 exams performed annually in the United States. Through the pioneering efforts of Dr. Abramoff, CMS has created a reimbursement model for Luminetics Core, which allows patients to continue to access this incredibly important exam. In Iowa, we have a team dedicated to bridging the gap to deliver care to those that need it most. Our group has paved the way for autonomous AI in an ethical way. Through continued vision research, we are committed to improving access to Iowans and veterans across this state. Again, our group would like to thank Chairwoman Miller Meeks, Ranking Member Brownlee, for allowing an opportunity to testify before you today. We have no greater priority than ensuring our veterans have access to the highest quality care, and we're privileged to continue in a path that benefits our veterans and our Iowans.
Thank you, Dr. Mansour. I'll tell Dr. Abramoff you did very well. If only we had the device and we could show everyone here. It's quite impressive.
Yes.
Mr. Blankenship, you're now recognized for 5 minutes to deliver your opening statement.
Thank you. Good morning, ladies and gentlemen. Thank you for the opportunity to testify today. Although I am the Chief Information Security Officer for ProCircular, a cybersecurity services firm based out of Iowa, I believe that my value to the subcommittee can be best vocalized as a recipient of VA care. I am an Iraq War veteran that led a squad of Marines in the Triangle of Death in 2004. Upon my return in 2005, I experienced some of the scheduling and administrative challenges navigating the VA. On the AI topic, as a cybersecurity professional, in recent years, I have seen firsthand the incredible benefits of using artificial intelligence and machine learning in cybersecurity, not only to enhance the accuracy and speed in detection models, pardon me, to identify threatening malware behaviors, but to automate research tasks. As others have articulated, the VA has mountains of data at its disposal. This data can be used by doctors, nurses, administrative staff to better serve veterans. However, the issue is that much of this data is either unstructured or difficult to query. Effectively, this data is unavailable to the staff and doctors to use in any meaningful way in a timely manner, simply because they're drowning in data. AI or machine learning algorithms are fantastic at pattern recognition and will continue to improve as results of those patterns are used to train the models further. Imagine how beneficial it would be for a doctor to have the top 5 recommended issues ready for review before seeing a patient. And those potential diagnoses and remediations would be based on decades of hard data and thousands of discrete data fields, rather than fallible human bias and individual best effort. genius intern that excels in processing large amounts of data, quickly and accurately making correlations based on historical facts and individual patient history. These recommendations could be given to the doctor as a force multiplier without cutting out the expert human judgment. It would allow the doctors to make use of currently unusable data to make real-time fact-based decisions and ultimately better serve veterans. My personal experience with the VA centered on administrative problems. After returning from a war zone, I went to the VA to get my hearing checked within weeks. The visit took most of the day, and the only thing that was accomplished was to get into the system and have an opportunity to be scheduled for a hearing test. I wasn't allowed to negotiate the date for scheduling like a normal doctor's office. I later received a letter in the mail informing me that my hearing test appointment was the following day, which I was unable to attend because of a conflict. And that was 19 years ago, and I've never been back. And I fully acknowledge that I chose not to use the VA because of my frustration with the scheduling process. However, multiply my personal experience times millions of veterans to understand the scope. If the scheduling process is frustrating and counterintuitive, effectively veterans are being denied care. Because it's been 2 decades since I've experienced firefights and suicide car bombs with no hearing protection, it's unlikely I'll be able to prove that my hearing loss is a result of military service. I want to say this super clearly. The focus isn't about my personal journey, but rather acknowledging that AI and chatbots or scheduling personal assistants can be used to streamline and achieve efficiency gains for the Department of Veterans Affairs. If we can do better to cut down cycle time and defects in scheduling and navigating a complicated system, fewer veterans will self-select out of the care they need and deserve. AI can be used for predictive analysis, for resource allocation. By analyzing historical data, AI can predict demand for healthcare services, enabling VA to allocate resources effectively and ensure timely access to care for veterans. It can also be used for faster diagnosis and treatment and research and development. However, I believe that by simply improving the administrative process, we can provide enhanced veteran experience. Thank you very much.
Thank you very much, Mr. Blankenship. It's really incredible the opportunities I think that we have, and as members of Congress, we have the very difficult task of making regulations and laws and legislating an area which we may not be as intimately familiar with as both of you are. I'll now recognize Ranking Member Brownlee for any questions that she might have.
Thank you very much. I must say, Mr. Blankenship, you're not the first to inform us that you've had issues with getting appointments and interacting with the VA. So I apologize for that. I think that, you know, in terms of the services that you're providing currently in your job, but AI in general could be a huge, and I believe this very, very strongly, could be a huge piece of the puzzle in terms of improving all of these systems, you know, within the VA. We have all of these old systems. I mean, one of my frustrations, having been on this committee now for 12 years, is whenever we stand up a new program, we need a system to support it, some automated computerized system, and that's always the delay of standing up these new innovations. And so I wish you would come to the VA and head up this idea of looking at systems throughout the larger enterprise of the VA and show us how we can improve all of those systems. I mean, the VA back in the day was a leader in electronic health records. Now we're sort of behind in that and following what private industry is trying to do and improve our legacy system that has been there for a long, long time. So we really need you and folks like you to help the VA move in this direction in a very precise way. So, and your point about mountains of data, I mean, this is the one advantage I think that the VA has over any other institution across the country is that we have an inordinate amount of data. And that's why so many researchers are attracted to working with the VA, because there is so much data there. But you know, how we can improve upon that is also, I think, thank you for your testimony today, and thank you for pointing out where we can do a much better job to serve our veterans. I appreciate it. Dr. Mansour, thank you for your testimony. I wish we could replicate you across the VA. I love your enthusiasm. I think you're the first resident that has ever testified in front of this committee, at least in my 12 years. So thank you certainly for being here. You mentioned, there are two areas that I want to ask you. One is you said this can all be provided, AI can be provided in an ethical way. And back to the chairwoman's original question, I want to hear a little bit about that. And also I'm interested to know if you have any data in terms of, I understand that the population in Iowa, there's about 10% that are suffering from diabetes, and how, if you have data to show how you improve those percentages.
Thank you so much. It is truly a privilege to be here today. So to your first question, delivering AI in an ethical way. Probably less than a decade ago, the landscape was completely different. And this is not a hype cycle. This is not something that is here and then gonna be gone and we're on to the next thing. So in order to have technology that is going to do those things you want it to do, increase access to care, reduce these barriers that we've all talked about, it has to be deployed in an ethical way, right? And there's two comments on that. So the one is machine learning and deep learning AI, assistive AI, all of these technologies we want to make sure that they're not inherently becoming biased, because you can run the danger of actually exacerbating issues that we're here talking about today. And so to that end, very grateful for the support, both of course from the university, but from our VA as well, that has allowed us, and of course Dr. Abramoff, who cannot be here today, to lead this landscape. And we had to analyze all of this, and a lot has been written now in the literature of what does it mean to be ethical. So we go back to kind of our principles in medicine, where do no harm, right? So non-maleficence, beneficence, autonomy. You have to respect a patient's right for self-determination, and then very importantly, justice. And so by engaging in a discussion with ethicists and really experts and thought leaders in this field, Dr. Abramoff and the team at Digital Diagnostics has really led the conceptual bioethical framework that has allowed for deployment of AI successfully. And I think, our motto is AI the right way, and we really mean that. None of this is going to be helpful if we can't find a way to do it ethically, in a manner that protects our patients first and foremost. And so that's kind of to that end. And then I knew this question would come about the data in Iowa, and I actually pushed internally for a lot of that. I think unfortunately it is a bit, it's confidential, but I will tell you this. We talked about 10% of our patients in the state of Iowa, about 10%, and really that's kind of reflected nationally as well. About 10% of the, so 1 in 10 Americans has diabetes. I will tell you, over 85% of those patients are not getting their annual eye exam. And we know that of those, probably 10% at least have diabetic retinopathy. And so I can't speak to the specific numbers in our own county. I wish Edgar County or state, I really wish I could. I want that data too. But I will say that when you look at the more granular numbers that are there, you really realize what is happening in our country, in our state. My parents immigrated from an impoverished, frankly, third world area, and so this is why I have this enthusiasm, because I'm here to stay, and people like me are here to stay, and we're going to make this difference. Right now, greater than 25% of counties in this country, the population doesn't have access to an eye care provider. So if we can deconstruct that work, especially in a state like Iowa, where the majority are coming from rural areas, small towns, I think it's hard to imagine a reality where we are not going to be improving the status quo.
Thank you.
Well, thank you very much, and I would say Dr. Abramoff and I have had this conversation and to see this come to fruition, and the primary impetus, as you said, was to get access to care. So this particular device can be placed in any place without an eye care provider and have an undilated exam. So if an individual is at a pediatrician's office and it's type 1 diabetes, and so they have the course of the disease, the length of the disease is important in the severity or development of diabetic retinopathy. But if it's at access at a clinic where they are with their family practitioner, with their internist, they don't have to see the ophthalmologist, but the AI part of it, which allows that to occur through machine learning, through repetitive images that were, all of those were collated, examined, and then developed into an algorithm that says this individual needs to have further care, not just an eye exam in a year. So the ability to disperse that district-wide, statewide, nationwide, I think is extremely powerful. And it has both, as we said to begin with, prevention, affordability, and access. So those things that are critically important to us in healthcare. Dr. Mansour, can you expand a little bit more on AI research projects being conducted at the Iowa City Center for Prevention and Treatment of Blindness?
Absolutely, and thank you to the VA system, of course, for supporting this research that we do here, and many kudos and thanks and gratitude to Dr. Randy Carden, who is also not here, but also hopefully soon to be colleague and mentor. And we're doing quite a bit. So right now there's 8 open grants that are funding a myriad projects. We have, I think at the core, if I can boil it down, we're leveraging AI, deep learning, to our imaging modalities, which we have the state of the art here for our veterans in our Iowa City VA. And we're using the power of the machine learning in developing spatial recognition patterns of both the optic nerve and then areas of the retina as well. And we've talked a lot about diabetic eye disease, of course, because the implications are massive, but it doesn't stop there. Our team, led by Dr. Carden, is also investigating actively blood flow to the retina that may be affected in age-related macular degeneration, of course, which affects many people, many veterans, of course, and then nationally as well. Other sight-blinding diseases like glaucoma, which I'm sure you've heard of, multiple sclerosis, radiation-induced retinopathy, which is a disease that impacts the retina after having radiation treatment for cancer. And really one of the areas of particular interest, especially in patients who are combat veterans, is eye movement related disorders. And one just quick word about a project where we are actually using a virtual reality headset to capture the eye movement of our veterans in real time, and then using our machine learning algorithms to better understand how these eye movement disorders are actually then causing symptoms and how we can mitigate all of that. The point being, right now, with this immense data, we want to not just prognosticate and treat, but we want to prevent. So all of that coming out of our center here, which we're very proud of.
Thank you very much. Mr. Blankenship, I can see you smiling as we're discussing this, so it's definitely where your passion is. And I'm going to ask you to expand a little bit on the barriers you've experienced while working with the VA healthcare system. Not in a negative way. You're an entrepreneur. You use some of the challenges you've had to make a system better. And I think it's important for us to understand how we can help the VA to incorporate AI and AI that's going to help us with, again, affordability, access, and prevention.
Absolutely. So I think a quick win that we could have is just using large language models, ChatGPT, something very simple. And I know that ChatGPT is not the depth and breadth of AI and machine learning, but it's something that's very low-hanging fruit. If we use something like that to establish patterns in care, using that to draft letters and using a scheduling assistant from some large language model. I think that would have pretty immediate beneficial effects. That would be one. The other concept that crosses my mind is ensuring that we protect the back-end data. So anytime we train an AI model, there has to be a repository where all the data points are stored. And if those data points are used to train models that are outside of our system, then we lose control of those data points. It's effectively personally identifiable information and HIPAA data. The downside, if we don't keep control of that data, it's a data governance issue, is that those diagnoses or those data points might show up in other models. So we have to be very careful of that in our business, where we don't want a client's name showing up on another report. So although it's a lower risk for our organization, it would be a higher risk for VA.
And I think that is one of the areas that we're all concerned about, which is data governance and privacy. Thank you both very much, Dr. Mansour and Mr. Blankenship, for your testimony, answering our questions. Ranking Member Brownlee, would you like to make any closing remarks?
I think I just want to say it's delightful to be here and very impressed with everything that's going on here in the medical center and in the state in general. And I just, appreciate all of you in this room who are committed to supporting our veterans and making sure that they get the very best health care that they have earned and deserved. We feel very, very strongly about that, and we are continuously trying to improve upon that. And any feedback that you can give us in terms of what we can be doing to help you and what you're trying to do to help our veterans, we certainly want to hear. It doesn't always have to come through a hearing. You can contact us at any time, and certainly you can contact me at any time. So please do that. And again, I just thank you from the bottom of my heart for all of the services that you provide to our veterans and the quality health care that you provide.
Thank you, Ranking Member Brownlee. It has really been a pleasure to be with you all here in Iowa's 1st Congressional District. I want to thank everyone for coming out today, our witnesses, the VA, and also especially thanks to the staff, both on the Democrat side and the Republican side, as well as my district staff. So thank you all for that. Innovation in veterans healthcare space is an important topic, and it's a duty of ours. And Iowa is doing amazing work in this space, and I'm proud to highlight it. We owe it to our veterans to ensure that they receive quality health care and access to that quality health care. Again, I'd like to thank Ranking Member Brownlee for coming out to my district, and I look forward to going to hers later in this year. I hope to continue working with our colleagues across the aisle to ensure that we do our duty as Congress and serve those who served us. The complete written statements of today's witnesses will be entered into the congressional hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objection, so ordered. Thank you all so very much for participation in today's hearing. This hearing is now adjourned. It seems like a little bunch. Yeah, well, yeah.
So I tell people I'm the dean.